Hello, everyone. I am Lawanda Townsend. Today I will present somatic symptoms and related disorders. So, somatization is the expression of physical symptoms in response to psychological stress. Examples of these body symptoms include pain, nausea, dizziness, fainting, and unusual movements. Different stressors, both positive and negative, can play a role in causing these physical symptoms. Physical expression of stress or emotion happens in all people. This is the mind-body connection. When the expression of these physical symptoms is severe enough to interfere with everyday activities, somatization requires treatment from healthcare professionals. Let's look at the history. So, starting in the ancient days, the earliest recorded descriptions of conditions resembling hysteria are found in the Kahun Papyrus, which is an Egyptian medical text. This document associates various physical symptoms in women with the movement of the uterus within the body, proposing treatments like fumigation to coax the uterus back into place. We then see this again in classical Greece, where we get the term hysteria. Hysteria is derived from the Greek word hystra, which means womb. Hippocrates, often called the father of medicine, believed hysteria was caused by a wandering uterus, a notion that the uterus moved throughout the body, causing various symptoms such as anxiety, fainting, and convulsions. This was seen as a uniquely female condition. Plato then reinforced this idea, describing the uterus as a living entity that could cause disturbances when it was unhappy due to lack of conception. We get to the medieval times, and no, it doesn't get better. During the Middle Ages, hysteria was often seen through a spiritual lens. Symptoms were attributed to demonic possession, witchcraft, or moral failings, particularly in women. Treatments included exorcism and other religious interventions. Moving on towards the Renaissance period, we had medical advancements that began to challenge the supernatural explanations. The focus shifted toward physical explanations for illnesses, although somatic disorders often remained mysterious. René Descartes was the person who introduced mind-body dualism, which reinforced the separation of physical and mental health, complicating the understanding of somatic disorders. And hysteria remained a largely female diagnosis. During the 17th and 18th centuries, physicians like Thomas Sydenham described hysteria as a neurological condition. It was no longer strictly tied to the uterus, and it was recognized that it could occur in men. However, it was still attributed to a delicate constitution or emotional weakness. In the 19th century, we saw Briquet syndrome, first described by Paul Briquet in 1859. It was described that patients feel that they have been sickly most of their lives and complain of a multitude of symptoms referable to numerous different organs. This conviction of illness persists despite repeatedly negative and unrevealing consultations, hospitalizations, and diagnostic procedures. And patients continue to seek medical care, to take prescription medicines, and to submit to needless diagnostic procedures. Then we see Jean-Martin Charcot, a French neurologist, extensively studied hysteria at the hospital in Paris. Charcot used hypnosis to treat patients and argued that hysteria was a neurological disorder. Everyone knows Sigmund Freud, who was influenced by Charcot. He proposed that somatic symptoms could be manifestations of unresolved unconscious conflicts and coined the term conversion disorder. Freud's work with Joseph Breuer, detailed in studies of hysteria in 1895, led to the development of psychoanalysis. This marked a significant shift from somatic to psychological explanations. Later, we see the biopsychosocial model emerge. This model recognized the interplay between biological, psychological, and social factors in the development of somatic disorders. Somatoform disorders was then included in DSM-3, and it was used to classify conditions like somatization, hypochondria, and conversion disorder. We also find psychogenic pain and atypical somatoform disorder. The DSM-3 criteria for somatization disorder required 14 somatic symptoms for women and 12 for men, from a list of 37 symptoms that Briquet came up with in 1859. The DSM-3 criteria for somatization disorder was criticized for being developmentally inappropriate for children and for being extremely difficult to use. The DSM-3 criteria also led to somatization disorder being rarely diagnosed in children. Due to criticism of the DSM-3, the DSM-4 tried to simplify the process. So, somatization disorder needed only 8 out of 32 symptoms instead of the previous 14 or 12. The DSM-4-TR distinguished between 4 somatoform disorders: hypochondriasis, pain disorder, somatization disorder, and undifferentiated somatoform disorder. However, there were significant overlaps between these disorders, and the boundaries between them were unclear. So the name was changed. Part of one of the changes they made was that they changed the name somatoform pain disorder to just pain disorder. And it was then proposed that when the DSM-5 was created, that they replace these 4 main somatoform disorders with 2 diagnoses: somatic symptom disorder, which is shortened to SSD, and illness anxiety disorder. However, in the current form of the DSM-5, we have multiple diagnoses available, not 2. In the somatic symptom and related disorders section, you can find somatic symptom disorder, illness anxiety disorder, functional neurological symptom disorder, which was formerly conversion disorder, psychological factors affecting other medical conditions, factitious disorder of self or others, and unspecified or other specified somatic symptom and related disorder. There are several other changes made, including emphasizing the degree to which a patient's thoughts, feelings, and behaviors about somatic symptoms are disproportionate or excessive, and no longer requiring the absence of an adequate medical explanation for a somatic symptom. So you could have both a medical symptom and a somatic symptom. Adding psychological factors affecting a medical condition and factitious disorder to the new somatic symptom and related disorders category, removing pain disorder as a separate diagnosis, but making it a specifier for SSD with predominant pain, and diagnosis of hypochondriasis, pain disorder, and undifferentiated somatoform disorder have been excluded. So they are no longer found in this section. Today, there are several criticisms in current diagnosis criteria as well. Diagnosis inflation and inadequate field testing have been reported to be the major criticisms. There is a high chance of misdiagnosing a medical illness, including chronic pain conditions such as mental illness. They believe this is possible because now the 4 sections or 4 main sections are too broad. Patients with medically unexplained symptoms, patients with emotional distress, patients with typical chronic pain conditions, and patients with health-related anxiety would qualify for SSD, resulting in high variability. Other drawbacks of the DSM-5 SSD diagnostic category may be stigma, misdiagnosis owing to a failure to investigate new or worsening somatic symptoms, increased risk of receiving inappropriate psychotropic medications, and increased risk of women receiving the diagnosis. The prevalence of somatic symptom disorder is estimated to be 5 to 7% of the general population. With higher female representation, female to male ratio is 10 to 1 and can occur in childhood, adolescence, or adulthood. The prevalence increases to approximately 17% of the primary care patient population. The prevalence is likely higher in certain patient populations with functional disorders, including fibromyalgia, irritable bowel syndrome, and chronic fatigue syndrome. Moving on to the diagnostic criteria. Category A, you only need one or more somatic symptom that is distressing or results in significant disruption of daily life. B, excessive thoughts, feelings, or behaviors related to somatic symptoms or associated health concerns as manifested by at least one of the following: disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high level of anxiety about health or symptoms, excessive time and energy devoted to these symptoms or health concerns. And then C, although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent. The duration should be more than 6 months. You should also specify if it is with predominant pain, and this was previously pain disorder. This specifiers for individuals whose somatic symptoms predominantly involve pain. You should specify if it is persistent. A persistent course is characterized by severe symptoms, marked impairment, and 6 months or longer. And you should specify the current severity. Mild is only one of the symptoms specified in criterion B. Moderate is 2 or more of the symptoms specified in criterion B. And severe is 2 or more of the symptoms specified in criterion B are fulfilled, plus there are multiple somatic complaints or one very severe somatic symptom. So severe might be fainting or seizures. Clinical presentation. Individuals with somatic symptom disorder often present with multiple somatic symptoms at one time. These symptoms are significant enough to impair their daily functioning, such as preventing them from attending school, work, or family obligations. The symptoms can be localized in one spot or diffused throughout the entire body, and may be specific or non-specific, like fatigue. For somatic symptom disorder, a lack of medical explanation is not needed for diagnosis, as it is assumed that the individual's suffering is authentic. In fact, somatic symptom disorder is often diagnosed when another medical condition is present, as these two diagnoses are not mutually exclusive. Somatic symptom disorder patients generally present with significant worry about their illness. Their interpretation of symptoms are often viewed as threatening, harmful, or troublesome. Because of these negative appraisals, they often fear that their medical status is more serious than it typically is, and high levels of distress are often reported. Oftentimes, these patients will shop at different physician offices to confirm the seriousness of their symptoms. Here are differential diagnoses. So first, I wanted to point out that other medical conditions are a differential diagnosis. This occurs with some medical conditions such as fibromyalgia or irritable bowel syndrome. To distinguish from general medical conditions, ask if medications that normally work are effective, if there is a history of mental disorders, or if it is persistent without stress. Another, while there are many of these on here, I'm only going to point out specific ones. So you see panic disorder is listed, and so is general anxiety disorder. Individuals with GAD worry about multiple events, situations, or activities. The main focus would not be somatic symptoms or fear of illness alone. There's also depressive disorder. Looking at illness anxiety disorder. Illness anxiety disorder is the fear of having a serious illness despite few or no symptoms. Functional neurological symptom disorder, which was before conversion disorder, is where the focus is on the loss of function, not particular symptoms. There's also delusional disorder, body dysmorphic disorder, obsessive compulsive disorder, and factitious disorder or malingering. Malingering is not a diagnosable disorder, but it is included in the DSM. So, factitious disorder is intentional falsification or inducement of symptoms with the goal to assume a sick role for yourself or someone else. And malingering is falsification or exaggeration of symptoms to obtain external incentives, such as secondary gain. So you could look at that as I want to be on a wish list in order to get a prize, or I would like to be sick in order to get sympathy and have people bring me stuff or do things for me. Looking at risk factors, the temperamental risk factors are having a negative effect, better known as being neurotic. Anxiety and depression are common comorbid diagnoses that exacerbate symptoms. The environmental risk factors are lower education, lower SES, and higher ACEs put people at risk for developing this disorder. And the demographic factors, there is a higher occurrence among these demographics: women, elderly, unemployed, those with pre-existing physical illness, pre-existing mental disorders. There are also cognitive factors such as heightened pain sensitivity, heightened bodily sensations, and a belief in physical symptoms rather than stress and mental illness. Methods for diagnosis. So the first method for diagnosis is really a physical exam, which would be performed by your primary care physician. Any laboratory tests to rule out medical diagnosis, and I don't want to say actual medical diagnosis because a mental health diagnosis is a medical diagnosis, but they want to know if you have a physical diagnosis. And then you would move on to mental health assessment. I included those at the bottom because those are basically what you do when you go see a doctor. And then these are the questionnaires that you would fill out if your mental health professional or your doctor think that you have a somatic disorder. So the first one is the patient health questionnaire, which is the somatic symptom short form. This is shortened to PHQ-SSS. Then there's another health questionnaire. This one is the PHQ-15. The Whitley Index is a shorter form of the PHQ-15. And then there's also the scale for assessment of illness behavior, which asks behavioral questions. The PHQ-15, WI-7, and SAIB are considered to be very useful screening instruments to detect persons at risk for somatic symptom disorder, and a combination of these three instruments slightly improves diagnostic accuracy. Their use in routine care will lead to improved detection rates for somatic symptom disorder. This is just they treat it as it is described in the DSM-5 and not any of the previous DSMs. Cultural considerations. Culture plays a significant role in how people experience and express distress and how they present symptoms to the healthcare system. Some cultural factors that can affect somatization include expression of distress. Different cultures have distinct ways of experiencing and communicating psychological distress. Often, somatizing is due to stigma or norms. For example, in many Asian, Middle Eastern, and Latin American cultures, emotional suffering is more likely to be expressed as physical symptoms like headaches, fatigue, or gastrointestinal issues, reflecting a focus on the body. Age should also be considered a factor here because children often use these same complaints for emotional issues. Western societies may have more acceptance of psychological explanations for distress, but children often don't have the vocabulary to say what it is that is bothering them. And so they fall back on somatic symptoms. Failure to recognize culturally normative expressions of distress can lead to misdiagnosis or labeling behaviors as pathological. We also see stigma and awareness. In cultures with high stigma around mental health, patients may prefer physical diagnosis and treatment over psychiatric ones, influencing their presentation to healthcare providers. Providers must balance culturally sensitivity with the need to address underlying psychological issues compassionately and appropriately. Health beliefs and explanatory models can also be considered ethical norms, but I tease them out here. Patients' beliefs about their cause of symptoms may reflect traditional or spiritual views, such as imbalances in energy, ancestral influence, or divine punishment. Collaborating with patients to incorporate the explanatory models into treatment plans fosters trust and adherence. Language and communication barriers. Language barriers or differences in terminology for symptoms can complicate diagnosis. For instance, words like nervous in Spanish-speaking cultures have different connotations. Culturally informed interpreters can help bridge this gap. The role of gender. So historically, these diseases and hysteria have largely disproportionately targeted women as an effort to reinforce gender stereotypes. Modern clinicians must avoid gendered biases while acknowledging that cultural norms around gender may shape symptom presentation and healthcare seeking behavior. So more women will ask for help. That does not mean that more women have the disorder. Let's move on to ethical considerations. So we want to avoid stigmatization as the diagnosis can carry a risk of being perceived as all in the patient's head, which would invalidate their experience. Clinicians must validate the patient's suffering, emphasizing that the symptoms are real, even if they have no physical components and they are psychological. Informed consent and collaboration. So patients should be actively involved in discussions about their diagnosis and treatment. Explaining the mind-body connection without dismissing their symptoms is crucial for fostering understanding and trust. Equitable access to care. Individuals from marginalized groups may face systemic barriers, including limited access to culturally competent mental health services. Ethical care involves addressing these disparities and advocating for resources that meet diverse needs. Avoiding medicalization, but medicating. Over-reliance on medical tests to prove the legitimacy of symptoms can perpetuate unnecessary healthcare costs and procedures. Clinicians should balance thorough investigation with the need to avoid reinforcing somatic fixation. Confidentiality. Providers must respect patients' privacy and handle culturally sensitive issues with discretion and care. And that is true about trauma, family dynamics, or stigma. Intersectionality. Clinicians must consider how overlapping factors like race, gender, socioeconomic status, and migration history shape a patient's experience. Ethical treatment involves tailoring approaches to these intersecting identities. The best practices for culturally and ethically informed care is to provide culturally competent training to your providers. They should come from a place of trauma-informed care, so that you can approach patients with empathy, focusing on safety and avoiding re-traumatization. You want to look at holistic approaches, integrating physical, psychological, and cultural dimensions of care to ensure a more comprehensive and respectful treatment approach, and use of multidisciplinary teams Collaboration among medical, mental health, and culturally specific practitioners can enhance care. Also, participating in patient advocacy, advocating for systemic change to reduce healthcare inequities is a broad ethical responsibility for all of our patients. Cultural and ethical considerations are integral to our job. Clinicians must embrace a culturally informed, patient-centered, and ethically grounded approach that acknowledges the profound mind-body connection while respecting individual and cultural narratives of distress. This fosters trust, promotes healing, and reduces healthcare inequities. Let's look at treatments. So we're going to look at 3 evidence-based treatments, starting with CBT. I've provided some modules so that you could look at them on your own time. I won't go over them, but it just gives you an overview of what each model is about. So CBT is cognitive behavior therapy. It is where negative patterns of thought about the self and the world are challenged to alter unwanted behavior patterns or treat disorders such as depression. Studies have shown that cognitive behavioral therapy is associated with significant improvement in patient-reported functioning and somatic symptoms, and it adds to the decrease in healthcare costs. PDT, which is psychodynamic psychotherapy, is a type of talk therapy that helps people understand how their past experiences and unconscious mind influence their current feelings and behaviors. And it is based on psychoanalytic theory and the ideas of Freud. Recent advances in our understanding of these patients and their treatment suggest that even the most severely affected patients who primarily attribute their symptoms to somatic causes can be helped with psychotherapy. And indeed, there is increasing evidence of the effectiveness of PDT for this patient group. There was a recent meta-analysis conducted of 17 randomized controlled trials that showed that brief PDT was superior to minimal treatment as usual, or the waitlist control condition with small to large effect sizes, and that brief PDT performed at least as well as other bona fide psychological therapies, so at least as well as CBT. Treatment results were maintained for a long period of time, so in the long term. And finally, we have TMS, or transcranial magnetic stimulation. It is a non-invasive brain stimulation modality that allows selective activation and inhibition of neural circuits. TMS is a reasonably safe and well-tolerated intervention among patients with somatic symptom disorder, and it has promising outcomes. For this disorder, pharmacologic approaches should be limited. Although antidepressants have been used to treat psychiatric comorbidities such as anxiety, depressive symptoms, and obsessive compulsive disorder, SSRIs, selective serotonin reuptake inhibitors, and SNRIs, serotonin norepinephrine reuptake inhibitors, have also shown efficacy with the improvement of SSD compared to placebos. Patients should be started with the lowest dose and increase slowly to achieve a therapeutic effect, as patients with SSD have a low threshold for perceiving adverse effects, which would then introduce a new source of concern. So it should be avoided. Here are my references. Thank you for listening. I hope you have a great night. Goodbye.